Hi, everyone. Welcome to another episode of QuesCast, a podcast in association with Quesmed, where myself and Lara talk through clinical cases and hopefully go through some learning points that are beneficial to you and your training. We apologize for the long break since the first episode. We've basically been busy with various things, including applications, interviews, exams, and also just a bit of life as well. But to actually trace back to the first episode now where we asked each other things that we were interested in doing, I remember saying that I wanted to go into academic pediatrics, and I did get an ACF offer, but I've decided to turn it down and continue working for Quesmed for another year, actually. So we can reevaluate my interest maybe after the next episode, but that's what's been keeping me occupied. And Lara, what have you been up to?
Yeah, well, I imagine that you'll be doing this in 15 years' time. I think that you like this job maybe a little bit too much. I've been busy too. I applied for IMT, so internal medicine training, for those of you who are still undergraduates, and I am starting IMT in London back at UCL from August. So I'm looking forward to that, although a bit daunted about going back onto more rotas straight off the back of F2. But I'm looking forward to it nonetheless.
Brilliant. And hopefully, well, famous last words again, we'll hopefully be putting out more episodes after this.
Oh, yeah, definitely.
Right. Well, let's get into the second case then. So I was the FY2 on my Jerry's placement, and we were seeing all the new patients that were admitted to the ward overnight with the consultant. We went to see a 79-year-old male who had been admitted 48 hours ago with new delirium and breathlessness, was what it said. He was admitted to AMU. He was given 1 dose of treatment dose dalteparin and then switched to prophylactic dose the day before moving up to our ward, as it was felt that he probably had a chest infection. The patient's currently sat up in the bed. He looks a bit unkempt. He had quite a complicated social history, but he's just eating his breakfast and he seems fine. Any thoughts on that so far at the moment, Lara?
Okay, so you're seeing all the patients who've come in. I mean, it sounds relatively barn door for anyone who's done any Jerry's placements. 79-year-old come in with new confusion and breathlessness. Sounds like initially they treated him as a potential PE, but then obviously stepped him down. Either he had a CTPA or a D-dimer came back negative, and you're treating him as a CAP. I've met lots and lots of patients who are like that before. He's sat up, end of the bedogram, as we've talked about already multiple times. If you're eating breakfast, you're very rarely acutely unwell. So I wouldn't say that as a vignette is particularly worrying to me at that point. Is that kind of what you were thinking at this point? Nothing out of the ordinary, out of a ward round?
No, when I was preparing the ward round entry notes again, similar thoughts.
Yeah.
Nothing too out of the ordinary. So as you may have seen if you'd done a Jerry's placement before or worked with any geriatricians, they're very thorough, likely so, very holistic and very often systematic in their approach. So we went right back to the beginning. And looking at the original clerking plan, actually, they mentioned, as you had suggested, to go for a CTPA. But on the post-take ward round, actually, it was felt that because the patient was more likely suffering a chest infection, they started antibiotics and they actually didn't go ahead with the CTPA. So we went further back and we looked at the LAS clerking, which we'll talk a bit about later. And as a side note for you, those of you who are starting foundation training soon, the LAS clerking can have so much valuable information on it, especially if you're either seeing patients in A&E or on the medical take. And it can often have really useful information on things like their observations or an ECG at the time, or also things about their social history, which, especially in Jerry, sometimes if a patient's confused, this might be where you find, for example, contact details for a next of kin, for a collateral, for example. But anyway, on the LAS clerking, it said that the patient actually required 2 liters of oxygen when they arrived because he was hypoxic at 89%. And once he reached ED, his sats were normal, the oxygen was stopped. And it also said actually that when they reviewed him in his home, his initial blood pressure was 98/60. But in the ambulance, it went up to 105/80, and in ED, it was sort of around the lower end of normal. He's a known smoker with a significant PAC history, and other than that, his obs are normal when you're seeing him on the ward round. Is there anything else that you might be thinking at this point?
Yeah, and I think just as a little note as well, what the LAS clerking is. I think it's the London Ambulance Service. When it's just,
yes.
It's just clicked for me that we have YAS up here, which is the Yorkshire Ambulance Service. And I've worked here for almost 21 months, and that has only just clicked. You learn something new every day. So my thoughts at the moment, I think you're absolutely right. Going back to the beginning is, I think, especially what consultant geriatricians like to do. I don't know if we're going to go down this route, but cognitive bias is really prevalent. And by that, I mean, especially when you're a busy SHO on the medical wards, you see what's been done before. You see, oh, we're treating them as a chest infection. They are a chest infection from there on out. And actually, I think what these holistic consultants do is they take that with a little bit of a pinch of salt. Doesn't mean that anyone was wrong before, but it's important sometimes to take a little bit of a step back. So I've seen lots of consultants do that too. So I guess then, just to summarize what you've said in that part, is that this is a heavy smoker who had saturations of 89% at home, requiring 2 litres. He's quite hypotensive actually on his first assessment, but this has seemed to have settled down. And again, none of this is really screaming anything out of the ordinary. And again, I'm not particularly worried right now that they're acutely unwell. I think the fact that we have someone who was objectively hypoxic prior to admission is an important thing to think about. I think if he's also a smoker as well, and again, when you've worked a lot, you see this a lot more, it's what are his target saturations anyway? Is this someone with diagnosed COPD, undiagnosed COPD, and are their target saturations 88 to 92, in which case 89 is pretty bang on the mark, or is he someone who actually in the GP on previous admissions has been saturating at 98, 99%? So those are sort of the little things, again, that I'm thinking about. But like you've said, not a lot there that has made me think this case at the moment is out of the ordinary.
So at this point in time, and also just to answer your question, he wasn't a known retainer actually, so there wasn't anything about prior oxygen saturation targets either on the LAS clerking or on the on our notes. So when we reviewed him with the consultant, she was quite surprised actually that the post-take consultant had cancelled the CTPA given the LAS clerking. And her immediate gut feeling was actually this patient needs a CTPA. They were breathless, they were hypoxic, and they were actually hypotensive. And when you think about sort of the treatment algorithms for a PE, all of that can kind of play quite an important role. So I arranged the CTPA. It was vetted pretty instantly, and the plan in the meantime was to restart the treatment dose dalteparin. So he had the scan about 2 hours later. And I was coming back into the ward. I had some lunch, had some chips, and I was taking it into the doctor's office. And on my way in, the nurse in charge said that there was a doctor on the phone, handed me the portable phone. It was a consultant radiologist, and you can see where this is going. And they said to me that, do you have a 79-year-old patient who had a CTPA or that you'd vetted a CTPA? I was like, yes. And they were like, I've been trying to get hold of you for the past half an hour, actually. He has a massive saddle PE, an IVC thrombus, and also radiological evidence of right heart strain. And my eyes slowly widened the more as it continued talking. And kind of like that scene from Ratatouille with the chef's reading the note. And I looked through from the doctor's office towards the patient, looking at what he was doing, the patient. And he was just eating his lunch, and he was chilling. He was walking around with his lunch in his hand. Lara, what do you want to do now?
So I think you brought up a really important point earlier, and I'd be really interested to know what the decision was to stop the treatment dose enoxaparin and cancel the CTPA. It sounds like his Wells score would have been really high. That's when I guess we can talk a little bit about the Wells score, so that we weren't going to do a D-dimer. And actually, because someone has a chest infection, sometimes means that they're more likely to have a PE because they're prothrombotic, they've got an inflammatory process going on. So I think to stop that enoxaparin, I would have been interested why that consultant made that decision. Things change and times change, and someone's sort of clinical journey does move forward. So that doesn't mean that the decision at the time was necessarily wrong, but I'd just be interested to know a little bit more about it. I guess in terms of what you've said right now, you've had a consultant radiologist call you, which does happen, and you always know it's going to be a bad call. So we know that he's got a large saddle PE. So for people who are at home who don't know or haven't come across the term saddle PE, what that means is they've got a pulmonary embolism that is sat across the pulmonary trunk. So it's actually quite good if you look on a cross section, a CT axial view. You can actually see it looks like a saddle, but it's just sat across the pulmonary trunk. That means that you have a significant obstruction of blood flow to both lungs. So it's an important distinction from something like a segmental PE that only impacts certain little bits of the lung, so someone can compensate more. He's also got a large thrombus in his IVC, is that right?
Yep.
And that also does worry me, because that means that there's potentially more to come. This is someone who's extremely high risk of further PEs. So what I would do at that point is, you've done the eyeball test, which is good. So you know that he's probably relatively stable. I would go and see him, to be honest. On the consultant radiologist saying that, I'd ask for a full set of obs. I'd especially want to know what his oxygen saturations were, what his respirate were. I'd want to do a very quick A to E that we did last week, but he's talking, he's eating lunch, his airways patent. Chest, I think, is where we're going to probably stop here on B. So is he tachypneic? Is he using his accessory muscles? Chest expansion, have a listen to the chest as well. Very well may be a concurrent cap going along with this as well. And then know that he's hemodynamically stable. So what's his blood pressure? Is he like shut down? Heart sounds, is he very overloaded? Things like that before quickly getting to the end. When I got to E though, probably would have a look at his calves, because I think frequently that's forgotten. I think it's 95% of VTE or PEs come from DVTs. So it would be really important to look at his calves and then also ask him, has he had a history of any hot swollen calves? Yeah. After I'd done that, realised that he's stable, I'd buy myself a little bit of time, hopefully. I'd call the consultant, my consultant in charge, or the registrar. I think probably in this scenario, the consultant has asked for the CTPA. It's the consultant's decision, so I'd probably escalate it to them if they were really accessible. If they weren't accessible and the registrar was close by, I'd let them know. But very quickly, you would be doing treatment dose enoxaparin for this patient based on their renal function. So you definitely want to have a look at that as well. And then if he's got an IVC thrombus, that kind of complicates the picture a little bit more. Very rarely they put IVC filters in people. And that's more of a long-term thing that they can discuss. But that's sort of how I would approach it acutely. Is that how you approached it? Did you do anything differently?
Yeah. So as you can imagine, I didn't start eating my lunch at that point.
No. Put the chips, get cold.
He was so as I said, end of bedogram, still looking fine from the morning. He's airways patent, speaking full sentences, conversing with me as normal. He's not cyanotic, he's not tachypneic. His chest is there's some crackles at the bases, but nothing too
fancy.
Nothing too fancy, no. His sats are normal at 97%. And his blood pressure, the systolic is still around sort of 115, 110. But he's not tachycardic. His pulse is regular. His cap refill is fine. On E, as he correctly said, calves look fine as well, and he didn't mention any previous swelling or pain in his calves, and also he didn't have a previous history of any blood clots before. So completely normal examination, which is obviously very reassuring given the CTPA findings you've just been given. At this point, actually, it might be a good opportunity to talk about some of the scoring systems, seeing as you mentioned. So, off the top, Lara, do you know what his well score might have been? I don't mean to put you on the spot there. We can talk about it later.
I'll give it a good go. So the well score, again, for anyone at home, I imagine if you're doing finals, having just done finals or a little bit before that, you will have heard of it. It's a common exam question fodder. So well score, it's split into PE and DVT, and it's basically assessing the likelihood that someone has it. So if off the top of my head, for the well score for a PE, I think the first one is like is PE the one or most likely diagnosis, and then it's things like, are they tachycardic? So is it more than 100? It's things like, do they have a current history of malignancy or in the last 6 months? It's, have they been recently immobilized? And I can't remember, there's definitely a couple more on there. but I can't remember what the other ones are. But anyway,
Yeah.
if it's more than or equal to 4 for a PE, they walk straight into a CTPA.
Yeah.
So what else is on it? I've completely slipped my mind.
So we'll go through them. So you talked about if there's any signs of DVT, if they're tachycardic, if you think P is the number one or most likely diagnosis, if they've had any immobilization or recent surgery, if they've had a previous DVT or P, if there's any hemoptysis, and as you said, if there's any malignancy. And also, actually, one important point about Wells scoring, actually, as Dr. Wells himself says, is that, and apologies, this is obvious, but you're supposed to only use this scoring system after you've taken a history and clinically examined the patient. It's not something that you should be doing, especially after doing a D-dimer, for example, because as we know, a D-dimer can be positive in so many different scenarios. So this patient would score for, and this is another interesting point, actually. So Lara, would you use the information we had from the LAS clerking, for example, to inform your scoring, or would you use some of the information that we got afterwards? Say before we got the CTPA, would you use the ward round morning numbers or the LAS numbers?
I think that's a really good question. I think if I'm being honest and I were seeing a patient and I was reviewing them, for example, we have same day emergency care in the hospital and GPs review patients and send them in as query DVT or PE. I would often actually assess the Wells score based on the person that I saw in front of me. But I wonder then if you're right, maybe we should be assessing someone based on when they first present. And actually we're saying at the time of presentation, how likely is this presentation a PE or VTE in some respect? So I think you might be leaning towards saying LAS, but I think if I'm being honest, I probably would do it on the person in front of me.
Interesting. Yeah. So the thing is that before actually, as I said, the consultant said pretty much straight away on reviewing the history, he's going to need a CTPA. So actually, in hindsight for this scenario, I guess it's a bit arbitrary when you would. But moving forward, actually, with some of the other scoring systems, which we'll talk about, we actually ended up using his LAS numbers and findings just because we already had a high suspicion beforehand of it being a PE. He's gone on to have the CTPA and it's shown a PE. And the consultant felt on the basis of, being safe, that it would be better to actually use those numbers rather than the more recent ones, because it may have been that at the point at which the LAS came and seen him, he may have already had the PE at that point. It's hard to say. So Wells scoring is one scoring system. Have you heard of the PERC score?
I have. It's the PE rule out criteria, and it's relatively a la mode. I don't use it that much, to be honest, because the people that I see come in with high Wells scores at the moment, especially on A&E. But from what I understand about the PERC score is that it's basically used as a rule out tool, because essentially we throw D-dimers at so many people and you get yourself in like a bath of real hot water. And actually we shouldn't be doing D-dimers on people who have an extremely low suspicion, basically no suspicion of a PE. Again, I wouldn't know the criteria within a PERC score. I think I'd look it up on MD Calc, but I think that's predominantly what it's used for.
Yeah, exactly. So as the name suggests, they're rule-out criteria. So it's a set of, we'll go through the criteria, but essentially if the answer to any of those is yes, then you can't rule out PE. Things it looks at are age, heart rate, oxygen saturations, if there's leg swelling present, if there's any recent surgery or trauma, if there's prior PE, DVT, or if any hormone treatment is being taken. So a lot of sort of the standard risk factors that are also used in the Wells scoring criteria. And immediately the age cutoff they use is 50. So actually, we can't use it anyway. And also this patient was hypoxic initially as well. So they would have had 2 reasons. But that was just more for the benefit of our listeners to go through, what sort of tools you might use when you're seeing that patient for the first time. And
also, can I just say as a little note, as if there is an actual Dr. Wells, could you imagine assigning your name to such like a like worldwide, I mean, not worldwide, but sort of national criteria. And then you just throw out that you are the Dr. Wells. I think that's really impressive.
Yeah. And unsurprisingly, it wasn't Dr. Perk who came up with the Perk
No,
score.
no. That would be really, that would be such a coincidence if his last name was PE rule out criteria.
Yeah. And the last scoring system actually that I wanted to talk about for PE is the PESI score. Do you know what the PESI score is, Lara?
I have come across it, but I don't use it. I don't think I ever have.
Sure. So this is a pulmonary embolism severity index score, and it predicts the 30-day mortality of patients who have a confirmed PE using 11 criteria. I'm not going to go through all of them, but this patient scores for the tachycardia, which we're going to use the prior tachycardia, his age, and his sex. And that gives him a score of 111. Which puts him into class 4, which is the high risk class, which means he has a 4 to 11% 30-day mortality, which is quite high actually.
That is high.
Yeah. Any ideas what we would do now, Lara, at this point? I know you've mentioned speaking to the consultant, and we'll get to that. But before you've spoken to the consultant, and obviously the patient's not right here in front of us, is there anything that you would do to maybe make a start on a plan? Or what you might suggest to the consultant as what you think we should do?
So I think another aspect that we picked up on the CTPA is this person has evidence of right heart strain. And that is actually quite unusual in a pulmonary embolism. And that means that they basically have a whopping PE. So I think we start off at the bedside, and then we do bloods, and then we do imaging. We already have the CTPA, but that doesn't mean that we should neglect other investigations. So the first thing at the bedside in someone who I've told has right heart strain on a scan is I'm actually going to want to get an ECG. I would like to look at a previous echo if they've ever had one. He's a very heavy smoker. Maybe he already has some sort of like pulmonary arterial hypertension, something just I think to consider. In terms of other bedside tests, he's off oxygen at the moment, isn't he? I don't think there's anything warranting, he's not tachypneic, there's nothing warranting an arterial blood gas. In terms of bloods, when we're starting to think about treatment for someone who ultimately might end up on something like a DOAC, you have to have pre-DOAC bloods. So if you're going to bleed them anyway, I would just make sure that you've got your USNEs, your LFTs, you need a basic clotting, and you'd want a full blood count as well to make sure that they weren't anemic.
Yeah.
Then in terms of treatment, there are two basic lines that we can go down. It's whether someone's hemodynamically unstable with a pulmonary embolism, or whether someone's actually stable and we can just treat with treatment dose. From what you've said, it doesn't sound like he's hemodynamically unstable, but I think the fact that he has some right heart strain on his CTPA, it probably warrants a bit more of a discussion. Another thing that I'm thinking as we're kind of talking through this case, and I think it's really important if you're going to start on an elderly medicine or a geriatric placement, is what is this person's ceiling of care? Like, what other comorbidities do they have? We now have a really significant finding of an elderly gentleman who's got a saddle PE and right heart strain. What is his resuscitation status? Has this been discussed? And I feel like maybe as a F2 or an F1, this is actually an appropriate thing that we can start thinking about and then maybe broaching that discussion. Some patients, I've had so many different escalation discussions. Some people are very clear, absolutely not, I don't want to be resuscitated, I don't want to be in intensive care, and other people have quite different thoughts and opinions on it. So I would say, especially in elderly medicine, just thinking what can we do doesn't always mean what should we do. And I think in someone who is right heart strain, who's older, it's worth a discussion with, again, a senior about what level of escalation do we think it's appropriate, and then having that discussion with the patient and their family if needs be. I also remember you saying that at the beginning of this, he had a new onset delirium, and there's potentially a confusion aspect to this. And especially, again, in elderly medicine, where medicine is really holistic, you've got to think about keeping next of kin informed, getting next of kin's opinion on what would have been in the best interest for that patient. So it does become a bit more of a comprehensive assessment in elderly medicine. And like I said, just because you can do something doesn't actually always mean that we do stuff, especially in patients like this. So I guess I'd like to know a little bit more about the patient themselves, Priyesh? What do we know a bit more about his background and things like that?
Sure. I mean, one of the interesting, funny things about the delirium actually is with hindsight, actually, this patient was actually, he was just very politically incorrect in the things he was saying at certain points.
Oh, right. Classic.
And actually, and he had full insight actually into what he was saying. So in terms of the delirium, actually, it turns out actually that's just it was actually just the patient's personality. He was quite suspicious of people, and when we took a collateral from his wife, who he had split up with and wasn't divorced but also not living with, she said actually this is kind of normal for him.
Normal for him. That's good to know.
But you mentioned quite a few things, actually, quite a few really important points. So just to sort of go through some of them, and also a bit about what the hospital that I was working in, the hospital guidelines for you would do is, obviously you picked up that there's some radiological evidence of right heart strain, and a CT scan isn't necessarily the best imaging modality to pick that up, and also to give a more sort of overall picture of how the heart is functioning. So exactly like you said, you want to get an echo done. In addition, actually, the our local guideline recommends doing a troponin as well at that point as well, to assess heart function. So troponin and an echo. And the reason for that is if they have further evidence of dysfunction or a positive troponin, it means that they just need to have much more close monitoring while they're in hospital. And it also means that as part of their SOS plan, if they are to deteriorate, then they should have thrombolysis. And as you correctly said as well, this is someone who's probably going to need to be on a DOAC long term. And because of sort of the timeline of the events and the acuity, like you said, you want to escalate. So I actually spoke to the hematology registrar about this patient because, like I said, they potentially had a PE a couple of days ago, and then we've only kind of picked up now. They've had one treatment dose, one prophylactic dose, and they're also just walking around and acting normal as well. So actually, again, they essentially said continue the treatment dose, low molecular weight heparin, and if they're unstable, then you would start thrombolysis. And again, obviously, they said get the echo done as well. And in the end, this was around 4:30 p.m. when I'd had this conversation with the registrar, and the patient was actually getting very agitated and was trying to abscond and leave as well. But I'll leave that that's another story. Our consultant had liaised with ICU as well because it was getting close to out of hours. It's just a patient to be aware of. And actually, upon speaking to the ICU registrar, they said, I'll come up to the ward and do a bedside echo as well.
Oh, brilliant.
The hematology registrar actually mentioned something regarding the patient's mobility as well. Do you know what they might have said?
So in terms of his mobility, it's always something that we consider in especially older populations is when we're thinking about anticoagulating someone who you said is not confused but quite agitated. We always have to think, I guess, about the risks and benefits of anticoagulation. And is this person who frequently falls, are they at risk of falling? And if we're putting them on heavy hitting anticoagulation, would that be a concern? It's never a contraindication to providing anticoagulation in reality, but I guess it's an important consideration. Another thing that I'm thinking of is, why has this gentleman developed a pulmonary embolism? If he is a mobile guy, doesn't have any other clear risk factors, I don't think he's taking any hormonal treatment. Don't think he's been on a long flight. Yes, you can have unprovoked PEs, but I think that would also be at the back of my mind, that to have such a massive PE and then have a huge clot stuck in your IVC, is there something else maybe more sinister going on as well? Is that the sort of things you're discussing with the hematology reg, or was it something different?
Actually, no, but we'll get back to what you were saying afterwards. So the registrar advised that this patient remains bedbound actually, and also use a bedpan for toileting as well. Does that give you any clues about what they may have been alluding to there?
I wonder if it's to do with venous return to the heart. I don't know. If you've got a massive clot in your IVC and you're increasing your needing to increase your cardiac output if you're out running around, if that increases the risk of further PE, or potentially when he's got, I guess, he doesn't have a huge, if he's not going around running marathons, if he went around running marathons and he has this huge saddle PE, he would probably have like quite a severe hypoxic event and potentially go into cardiac arrest. Is that the sort of thing that they're getting onto?
Basically, yeah. So it's based on, actually, this is sort of a more traditional way of thinking, actually, where patients with high clot burden, if they ambulate, there's a school of thought that on ambulation that can actually dislodge further clots when you have a particularly big clot, and like you said, cause further damage and can lead to a fatal PE. I did a quick literature search just before we started recording, and there's been multiple systematic reviews and even meta-analyses now that have sort of demonstrated that as long as the patient is on sufficient anticoagulation, so whatever the treatment dose or DOAC, that there is actually no increased risk of mortality with early ambulation.
Okay.
But yeah, that was interesting. Again, it's another thing where I guess keep it safe, just keep them bed bound.
Yeah. Sounds like he might have been a tricky gentleman to keep bed bound, though. He sounded very ambulatory.
Yeah, and actually, when I was on the phone to the heme reg, I remember they were saying, what's all that noise in the background? And it was this patient was trying to abscond and was screaming at the nurse.
Yeah, it's always the way, isn't it?
Going back to what you said earlier, exactly, especially in this population of patients, starting anticoagulation is actually quite a big decision, because with that, as you correctly mentioned, there's going to be an increased risk of bleeding, and in patients who maybe aren't so stable on their feet or are at increased risk of falls, it becomes an important discussion that you need to have about whether the risks outweigh the benefits. In this scenario, actually, so he ended up having treatment dose dalteparin for a few more days, and he was discharged on DOACs.
Yeah.
But as you said, it's a very important discussion that often needs to be had. Sometimes next of kin are involved, or whoever else the patient lives with, to give a bit more information. And as you said, with such a large blood clot, it does raise suspicions about if there was a potential underlying cause or anything that could have triggered it, and especially potentially something more sinister. So during his inpatient stay, he did have a CT thorax, abdomen, and pelvis to look for a malignancy, an underlying malignancy, and in the end, it didn't find anything.
No.
So he did just, on a Tuesday morning, decided to develop a saddle PE. I guess it does happen.
The body does what the body wants. So I'm interesting, Priyesh. It's an interesting case. Thank you for bringing it. I guess I have a couple of questions. One about being the role as an SHO, and I guess kind of not mediating is the wrong word, but kind of enabling quite high level discussions about treatment and how you feel doing that between like a consultant radiologist, a hematology registrar, and then your own consultant, how you felt within that, kind of bearing that responsibility. And I guess another thing that I wanted to kind of touch on maybe in this case is how you think the days leading up to the consultant that you were with, seeing them, how that maybe clouded the kind of clinical picture. I'd be quite interested to know what you think about that.
Yeah, so in terms of sort of how you go about managing a patient like that with quite a significant diagnosis, or with a high mortality, I think one thing that was very calming was how stable the patient was and how normal they seemed. I think if this is a patient who was desaturating, was breathless in front of me, and was having more deranged obs, it certainly would have been a lot more stressful. But because he was so stable, things went quite smoothly, actually. I mean, the consultant that I was working with this was her first year as a consultant, and I'd worked with her when she was a reg and I was an F1, so we had quite a good working relationship, and I was saying, this is the situation. What would you advise? This is what I think. I've looked at the guidelines. This is what they suggest. And she agreed with that and said, because of how it's such a big PE, speak to hematology as well. I'll speak to ICU in the meantime. So actually, in that situation, things went quite smoothly.
Yeah.
I think, being in hours, having a supportive consultant, and the patient being having normal observations and otherwise acting normal, I think made it a lot easier than it could have been. And like you said with cognitive bias earlier, this case actually showed me just also sort of how much there is to know, and how much of a long way I still have to go, because
Yeah.
when I was preparing the ward round entry notes, I effectively went off of the previous day's ward round entry, which is very common practice. You'll often look at the day before. You might paste in some of the problem list, and then you'll go through them, check what's still relevant, what isn't, and you kind of work your way through from there. But actually having the consultant say, no, let's go back a few days, let's look at the LAS clerking, let's look at the ED clerking, let's look at all of their obs, just goes to show how important that can be, because as you said, things can be missed if you kind of just always go off of what was said the day before without doing your own sort of due diligence.
Yeah, and I think that's definitely true. I guess also when you're saying that, I completely agree. But I also think there's a comment about time here. And if you're seeing 30 people on a ward round, if you've got a consultant, like you said, who's very supportive, who says, let's take our time to do a really thorough job here, then that's great. Sometimes I've been on ward rounds where you have to copy and paste, and I just, I hate it. But you kind of have to, because that's the way that the NHS in the world works at the moment. But yeah, a really interesting case. So what would you say, I guess, some of your, if you had to say, we'll do it at the end of everyone now. What are your 3 learning points from it?
Sure. So I think number one, always look at the clerking from the ambulance, especially for any newly admitted patient. As I was talking about earlier, can have some really important information that can be difficult to get to when you're with the patient in that moment. And it also sort of helps build an image of that initial first presentation. That would be the first thing. I think the second one can be that patient appearances can be very misleading. This patient looked very well clinically.
Yeah.
Honestly had no reason for me to think of anything sort of sinister or serious, but in the end, he had quite a very serious diagnosis with quite a high risk of mortality as well. So that's another thing. I guess end of bedogram, good for in the moment, but in terms of underlying pathology, isn't necessarily the best. And then I would say lastly, knowing how to access your hospital guidelines and protocols, because in between the various phone calls, I was going through the intranet, and to be honest, when I went through the protocol, even though I still would have called the hematology registrar, a lot of what she said was in that guideline.
Yeah.
And I think knowing where to find the guidelines and the protocols, or your grey book if you have one, will save you a lot of time and phone calls to specialties who basically may end up kind of telling you something very similar.
Yeah.
Those would sort of be my main takeaways.
Your main takeaways. I was just going to say, I think it sounds like you would have done very well in the SJT. Local hospital guidelines.
How about yourself, Lara?
In terms of my 3 takeaways.
Yeah,
So
how did you find the case? Was there anything in particular that you would take as well?
I think definitely, I thought it was a very interesting case. I think, like you said, cognitive bias, we have to be aware of it. Even if you can still take forward important things that people have done before that's been really useful, and like a really good clerking, really good history, really good examination, that isn't the totality of the job that you're going to do today. You're not just taking stuff forward, you're taking it on board, but you have to make sure that you keep you don't become narrow-minded or biased to what's happened before. I also think that you made an excellent point that I'm going to think a lot more about the Wells score and using these scoring systems and how we use them at a point in time. And should we have used, when we do the Wells score for this gentleman, should it be when he first came in by the ambulance or the person that you're seeing in front of you? I think that's something I'm going to think a lot more about. And then I guess you're right as well in the patient who's not someone who's on your radar, who is someone who you're worried about, and you can get a little bit of a curveball at work when you get this investigation result that is so out of whack with what you expected it to be. And I guess being resilient to that, but also flexible, and then kind of shift how you thought your day was going to be. Do you know what I mean? I always find it quite stressful when you get a CT scan result, someone you weren't worried about at all, and you're like, oh gosh, I missed that, or something like that. So I think those 3 things, but I thought it was an excellent case, and it's nice to think about the role of an SHO in like managing acutely making sure someone's safe, and then kind of enabling more senior people to make plans. whilst also learning on the job, because like you said as well, we all have a really long way to go, and it's good to remember that we're not supposed to know everything on day one. Yeah,
exactly. And also, actually, while you were saying that, I also made me think as well. We've talked about various sort of scoring criteria, and those can also be very helpful in helping you make those decisions. But also, those aren't necessarily hard and fast rules either. And
no,
as we saw, there was a bit of a grey area with this, in terms of sort of when we should be using OBS from when they first presented versus when they were on the ward. So, whilst those scoring systems are there, sometimes you may have to sort of move away from them, use senior input, like my consultant saying he needs a CTPA, based on the clinical sort of suspicion. We didn't do any sort of scoring for that.
no.
Yeah,
so
that
great.
was my case.
It's an excellent one. Okay, I'll have to think about the one I'm gonna bring next. But yeah, thank you so much, Priyesh, for bringing that, and thank you anyone who's listening at home. We're going to bring the next one out sooner rather than later, we promise. Now that our applications are kind of settled and sorted. So yeah, thank you very much.
So that's the end of episode 2 of QuesCast. We hope you found that interesting or helpful, or you learned a few things from it. As we said in the first episode, if you have any feedback, any suggestions for improvement, apart from maybe being more consistent, please either comment on the YouTube video, send us an email at info@quesmed.com. This will be available on YouTube, Spotify, and also Apple Music. So hopefully not such a long gap until the next episode. And thank you for listening. Thank you for watching.
Yeah, thanks guys. See you next time. Bye.
Bye.